So we will start with introductions. So I'm Rebecca Berens. I'm a family physician and I'm the owner of Vida Family Medicine, which is a direct primary care practice in Sugar Land, Texas. And I care for a lot of patients who struggle with various metabolic conditions, whether it's diabetes, metabolic syndrome, PCOS. So a lot of patients ask me all the time about GLP-1 medications. And so I've done a lot of reading to better understand and support those patients who might need to use those medications. But I also see a lot of patients who are in recovery from an eating disorder or have struggled with disordered eating. And so I'm very mindful of the potential implications of a medication that affects appetite in those patients. And so today we're going to be talking sort of a deep dive into these medications and the mental health impact. And with that, I will pass it to you, Sehrish, if you want to introduce yourself.
Sure. I'm Sehrish. I'm a therapist out here in Houston, Texas. I do see clients both virtually and in person. A lot of my specialty is, because I'm a certified eating disorder specialist, it's eating disorders quite a bit, chronic illness, and then mood regulation and mood disorders are kind of what I specialize in more so. So that's kind of where I come in.
So thank y'all so much for joining us today. And so, like I said, we are going to be recording this session. So make sure your camera is off and your microphone is muted. I think everyone is, but just so you're aware. And then we will be sharing the recording with the people who registered who couldn't attend live. And we will have time at the end for questions. So if you have questions, you're welcome to drop them in the chat as we're talking. If we're able to answer it quickly while we're going through, we will. But otherwise, we'll go through more of those at the end. So just to kind of set our agenda here for the talk, first, I'm going to be reviewing the different types of GLP-1 medications. I hear a lot of confusion from patients and even other clinicians about what they are, the various types, what their FDA approval indications are, and basically how these medications work. So I'm going to kind of review that. And I'm not going to be focusing very much today on the metabolic health impact of these medications, because we're really going to be talking about mental health impact. And so most of the kind of biology discussion that I'm going to get into is going to be relating to the effect in the brain. We could have a much longer, different conversation about all of the other impacts. So that's kind of out of the scope of what we're going to be talking about today. I'm going to talk about, as a result of those brain impacts of the medication, the common mental health side effects that we see. And then I'm going to introduce some research into potential applications in the mental health space for these medications. And then Sehrish is going to go into more depth about the potential mental health risks and benefits of using these medications. And we'll be talking about some sort of more practical applications that patients can think about, or that clinicians who are supporting patients can think about when talking about these medications. Very importantly, I think this is a no judgment zone. There's so much stigma and judgment around these medications that I hear from patients and in general public, and also from clinicians. And so I think the important thing here is that we're going to be talking about what these medications can do, the harms that we do know can potentially be a result of using these medications, but then also the fact there's still a lot we don't know. And so I think the main takeaway from today is going to be making sure that we are able to support ourselves, and if we're a clinician, our patients, in making the most informed decision when it comes to talking about taking a medication like this. All right, so this is first just sort of an overview of all the different types of GLP-1 medications and what their FDA approvals are for. And so I think I hear a lot in the community people saying like semaglutides. Semaglutide is one of many different GLP-1 receptor agonists, which is what the GLP-1 stands for. And they have been around for actually a very long time. Over 10 years, there have been other medications. So some of the ones that you see here, Byetta, Victoza, Trulicity, they've been around for a lot longer than the ones that most people are familiar with now, which is things like Ozempic, Mounjaro, Zepbound, and Wegovy that we hear a lot about in the news nowadays. But point being, they've been around for a long time. Initially, they were developed for treatment of type 2 diabetes. Weight loss was noted to be a side effect of the use of these medications, and that is how several of them ended up being studied and then approved for use in weight loss. But there's also been approvals, like you can see here, for semaglutide in reducing cardiovascular disease and chronic kidney disease in people with diabetes, reducing the risk of heart attacks and stroke in people who have coronary cerebrovascular disease, or basically vascular disease in the brain. And then for Zepbound, it is actually also indicated for the treatment of moderate to severe obstructive sleep apnea. And then you'll see at the bottom, retatrutide is another medication that is under investigation. So it is a little bit different than the GLP-1s, and then the GLP-1 and GIP receptor agonists, which is what Mounjaro and Zepbound are. It has an additional action. So these medications have been around for a long time. They're not going away. We're learning more and more about them, and there are a variety of indications why a person might be taking these medications. It's not all about weight loss. I'm going to cover briefly how they work. So the GLP-1 receptor agonist, that's what is in Ozempic and Wegovy. And as you can see, it works in various different parts of the body. We have in the pancreas, it in the is helping regulate glucose metabolism with insulin and glucagon. In the GI tract, so this is what a lot of people will hear about. It slows movement of food out of the stomach. It slows movement of food through the GI tract, and that is one way that it impacts appetite, because you feel full more quickly and for longer. But then there's also this impact on the brain that affects appetite and also other areas of the brain that we'll get into as well. GIP is what is added to the GLP-1 in Mounjaro and Zepbound, and that has some other additional impacts that you see here, but also has an effect in the brain. So, like I said, we're going to be focusing mostly on the effects in the brain today, and we're not going to be talking much about those other body systems. So some of the way that it works in the brain, it can suppress appetite and cause a sensation of nausea. It regulates release of various neurotransmitters, so serotonin, dopamine, GABA, and glutamate. So serotonin and dopamine, I think the general population is very familiar with nowadays. These are two neurotransmitters that are very involved in mood disorders, ADHD, other mental health conditions, but there's other neurotransmitters as well. And neurotransmitters are basically hormones in your brain that your nerve cells in your brain use to communicate with each other. And the release of those neurotransmitters, or the amount of those neurotransmitters, is implicated in a lot of different mood disorders. It also has an effect on reward pathways. So dopamine is one of the neurotransmitters that we get as a response to a pleasurable stimulus. So it's very heavily involved in things like addiction and also other behavioral things as well. And so it can have an impact on those pathways. It's also seen to enhance memory and decrease inflammation in the brain and promote generation of new healthy nerve cells. So quite a few different ways that it's acting in the brain. It's not just an appetite suppressant. And this slide here is just kind of reviewing in a little bit more detail all the various brain systems and how it is affecting some of those brain functions that we talked about. And again, I don't want to get too into the weeds here, because this could get very boring very quickly. So as a result of the way that it acts in the brain, there is a variety of mental health related side effects that you might see. So because of the way that it's interacting with neurotransmitters involved in mood, there's been studies showing actually both an increase and a decrease in depression and anxiety symptoms in patients using GLP-1s. So it can go either way. And then there are also studies that show a potential increase in the risk of suicidal ideation or thoughts of suicide in patients. And that has to do with the way that it's interacting with those neurotransmitters. Change in rewards behaviors. So like I said, the pathway that's involved in giving you kind of that pleasurable feedback to taking, for example, for like an addictive substance can be impacted. And there's actually some animal studies currently that are showing the use of GLP-1s in reducing substance use, not in humans, but in animals. And there are non-addictive behaviors that use similar pathways. So the concept of sort of like that emotional eating or other behaviors that you might be engaging in that are not necessarily healthy, but give you kind of that dopamine boost in the brain. Eating disorders, this is obviously, Sehrish and I both care for patients who are struggling or recovering from an eating disorder, and this is a big impact that we have to take very seriously when talking about these medications. There can be an impact on eating disorder behaviors both while taking the medication and also while coming off of the medication, which is an important thing to consider because most people are not going to take these medications for the rest of their life, even though that is the way that they are designed. For one reason or another, they may come off of the medication. And so we have to be mindful of the impact that could have both when they start the medicine on their eating behaviors and also when they stop the medicine. And then there can be potential interactions with medication. So because of the way that these medications slow the movement of food out of the stomach, we know that, for example, oral birth control pill absorption is affected by the use of these medications and may make them less effective. But there's also metabolic side effects of some mental health medications, particularly antipsychotics, but some antidepressants as well, that are using the same pathways in the brain. And so the use of the GLP-1 may reduce some of those metabolic side effects of those medications. And also the use of those medications might blunt the effect of the GLP-1. So just important to consider that the other medications that a patient might be taking, why they're taking them, and if that interaction is going to have a potentially negative effect or maybe a positive effect for the patient. And I will pass it over to you, Sehrish.
So with the psychological changes, we see a lot of the mood changes. I know Rebecca was talking about kind of how we see a little bit of everything on the spectrum. So for some, we'll see that improved mood, especially as the weight loss can increase kind of the self-esteem and that confidence. But then the reduction in body weight usually also leads to these physical benefits like improved sleep, reduced joint pain, and then greater mobility. And it can also look like reduced inflammation. The stabilization of the blood sugars, this is where it becomes really important, is because that can essentially affect a lot of the hormonal impact. And so if they have a more steady blood glucose level, we'll see that improved mood as well because they're getting that increased energy almost. But we also see that emotional blunting or numbness. So a lot of clients will talk about that blunting or numbness where they feel like it can be settling. They can feel like there's an emotional kind of like disconnect from feelings of joy or sadness. And that's also, again, going to be a lot of dependent on kind of how the food is coming into play and how that appetite suppression comes into play for them. That emotional sensitivity is a lot of what clients will also talk about. And so some clients have said, all of a sudden I'll feel like I am watching a movie and I'm very disproportionately upset, or over a small argument, I might feel like this is not okay or incongruent to what it should be. So there's also this heightened irritability or frustration that comes with it. What's interesting that I've seen a lot of too is that clients and patients will report feeling more energetic or euphoric. And a lot of the research that we have right now is from type 2 diabetes. And so what we're seeing is that because of that better blood sugar control, which is what gave them kind of that sense of accomplishment or motivation. And so what they're feeling of euphoria and elevated energy is just these clients who've had years and years of unstable blood sugars or high levels of A1C are finally feeling a level of consistency with their blood sugars. So really what that euphoria is stabilization in their blood sugars. And so, you'll see that clients who've, again, historically have been told, hey, just go lose some weight and you should be fine, or that should help, getting that motivation around daily activities like even exercising or socializing or engaging in any hobbies were really hard for them to consider. And so now that their blood sugars have gone from maybe the 400s, 500s, 300s, like these are clients who've had A1Cs of over 10 for years, are now having that ability of, hey, I can do these things. And because they can do those things, they're seeing those mood changes. The anxiety and depression can go either way as well. So some studies have suggested that they can definitely reduce symptoms. And that might be, again, that hormone effect on appetite regulation. and having that better metabolic control. And that can, again, overall well-being can be addressed there. But sometimes you might see this anxiety that becomes associated with just, am I going to be losing enough weight? What if this stops working? What if what I'm seeing? So you see the other aspect of this. You see people getting very detached, apathetic, even less responsive to situations that would typically kind of have an emotional reaction. And now they're seeing that bluntness again. And then that food related anxiety. And, we'll get into that a little bit more here too. But individuals with a history of maybe overeating, binge eating, or food related anxiety experience a reduction in these behaviors because of that medication, which is regulating that appetite. And now they have a decreased anxiety around food choices or meal planning. So, for example, clients who I work with, might be as close as having panic attacks, just trying to make day-to-day food choices. Like, am I doing this right? Like, how do I go about this? And you can imagine that creates such a sense of distress day to day. And now they're just much more calm in their control of their eating habits because some of those concerns or those distorted thoughts have kind of suppressed a little bit. And then conversely, we also have this other aspect of it, right? So those who have those changes in appetite and eating patterns, now there's this fear of, what about regaining the weight? What if I'm not doing this right? What if, every bite I'm eating, I'm concerned of, is this fitting in with what I should be doing? Sometimes people are told, hey, you can lose X amount of weight per week, or should be. And so if they're not meeting that, it's like, well, why am I not meeting this? Why am I not doing something right? So you can see how there's a shift in both. The social and identity shifts are interesting too. So again, the rapid weight loss can affect a person's self-image. And this can be whether they feel more positive about their appearance, or they might have a sense of almost confusion or discomfort as they're adjusting to this new body. It can be challenging, especially if they've struggled for weight for a long time. I do a lot of mirror work with clients, especially those that were concerned with body image concerns. It's almost that they don't recognize themselves because that shift is so rapid. And sometimes you see this change also happen in social interactions and relationships. And what I mean by that is they're getting a lot of different feedback from, we talk about trying to, I'm big on saying, hey, let's try to create boundaries with these individuals. But someone who's previously been overweight or may find it difficult to not only reconcile with their new appearance, but also, well, what if I start losing weight? I'm getting all this feedback. And what if I start gaining it back? Now I'm getting the opposite feedback. So something with these GLPs is that someone might lose a significant amount of weight in the beginning and then start regaining some of that, or plateau throughout this process. And so that expectation of, I should continue to lose, or, hey, now I'm not going to go out because I got all this positive feedback for losing this weight, and now I'm going to get that negative feedback of gaining it back. And this creates a lot of unexpected emotional challenges because the rapid changes in appearance and lifestyle can lead to that guilt of, maybe, again, going back, this is my fault. How much control? And sometimes with these GLPs, they don't have a lot of control. Just like in body image, we don't usually have so much control here. And so that can only exacerbate a lot of that. Next slide. And then with the appetite suppression, we talk a little bit about the normal eating pattern. So part of the whole GLP here is that we are affecting how people are having these the lack of intuition really is what's happening. And so a lot of my clients are not really eating regularly anymore because the whole idea is the suppression of food. And so especially if you're struggling with eating disorder, but even if you're not, the suppressing of the appetite can cause feelings of fullness, and then that affects the regularity and consistency of eating habits. So that overall makes it difficult to follow a balanced nutritional approach. What I'll see a lot of times, especially at the beginning, is clients will say, hey, I've gone through like an entire day without eating, or I didn't realize it until basically my sugars tanked. So sometimes clients' sugars will be up to 40 or a 50, and they don't really know what's happening, but they realize, oh gosh, I've actually forgotten to eat because it's almost that eating receptor is almost depleted. And so this can lead to more skipping meals, restricting even further, and you have to actively remind yourself. So I have clients setting timers or alarms to remind themselves to eat because that's no longer there. And so you can see how that can kind of exacerbate any disordered eating behaviors, even if a client doesn't necessarily have an eating disorder starting here. Now, there is also a decreased pleasure from food because, as Rebecca was talking about earlier, is that one of the side effects is you might have nausea around certain types of food or just in general. So some clients will say, now that I eat sugar or smell sugar or even have certain types of food that just make me feel almost physiologically ill. So now there's that food aversion that can potentially come into play here. And then body image and identity, I think we touched on this a little bit here, but with the GLP-1 medications, this can, what we've seen is that almost intensification of societal pressure to achieve this thin body. And we've seen that for quite a while, but now it's almost reinforcing a lot of these ideals and perpetuating that weight stigma. So people can now lose weight rapidly, but is that, if you're not choosing this, why aren't you? And so it's almost that this drug is becoming causing some vulnerability to internalizing that notion, the notion that we've had forever, that thinner is better, and it exacerbates eating disorders and that negative body image. And then there's also that fat phobia and stigma around there as well. So those that are in larger bodies could feel exclusion or discrimination, especially if they decide to use this drug, like Rebecca said. So there's this view that it's used as cheating, or there might be a pressure to maintain larger bodies in the face of this idealization of thinness. So we're seeing a little bit of both on both ends here. And again, that external pressure from friends or social media to maintain a certain body image even after weight loss. So the pressure can be overwhelming. This can again exacerbate that body dysmorphia. A person who's lost the weight might feel really anxious now about, again, like we talked about earlier, is what if I'm gaining again? What if this happens again? And a lot of times that is this idea that there's a certain level of weight you will lose before some of it kind of you stabilize back. And that's concerning, especially as the doses change throughout your treatment. And that's not always taken great with clients. And again, if they've been on this route of attempting to lose their weight cycling almost and going back and forth of that. So. And then this idea for potential for binge restrict cycles. So again, going back to this idea where clients are going maybe 8, 10, 12 hours without eating or struggling or not reminding themselves to eat, then all of a sudden they're eating, it kind of exacerbates that binge restrict cycle. There's a loss of hunger cues. We've talked about this, and then that intuitive eating disruption. So a lot of times, even if we've never had a history of eating disorders, we have to be very cognizant as we're kind of entering into this and making sure that we're remembering to eat. And so almost that intuitive eating piece needs to be manually kind of placed in. And then that food aversion. So now, with the loss of pleasure of certain types of food or just feeling nauseated around certain foods, it's kind of, making sure that we're still integrating these as much as we can. And that so from what I've seen is that clients in the first 3 to 4 days, usually it's once a week when they're taking the shot, the first 2 to 3 days is when they're the most nauseous, and then it kind of subsides. And so that's when so we'll kind of talk about doing a lot of these exposures or interventions or having certain foods that maybe didn't feel so great at the beginning of the week, maybe midweek or later on in the week, so that they're still getting some of those pleasures from those foods as the impact of the GLP or that feeling kind of subsides a little bit throughout the week as the dose kind of declines. Again, we talked about, the internalized weight. So a lot of what's concerning here is that even though there is this focus on the potential benefits of GLP-1 medications, and again, there is, especially for management, diabetes management, weight loss, it's going to overshadow the need to address deeper societal and psychological issues. Again, the health at every size approach, including the normalization of thinness. What does that mean like for body image and any systematic barriers that we're facing by just marginal groups, just in general? And so without addressing the root cause of eating, or just disordered eating, such as trauma, cultural pressures, societal weight stigma. Relying on these medications as a solution for all of that can be very problematic. And we want to approach and emphasize weight loss alone without considering these larger systematic factors are going to only alienate individuals struggling with these concerns. And so again, navigating this idea of self-worth beyond the appearance almost takes kind of this backseat. And we want to make sure we're integrating the entire self. And this starting in this weight cycling and access issue is another concern. If we're starting and stopping GLP medications, this can be, again, influenced by accessibility issues, cost or availability. And when people cycle on and off this medication, you see almost like a yo-yo dieting effect. And that can definitely contribute to emotional distress, that negative body image, and even that weakened metabolic state. Because like Rebecca talked about earlier, it's working on your metabolic and your psychological aspects. All those hormonal levels are kind of getting a little whacked out. And so it's like, if we're going on and off of these, then how are we kind of keeping those consistent? And then impact on individuals with eating disorders, like we talked about, for individuals with eating disorders already. And then if they're weight cycling, this is going to only activate feelings of guilt, shame, and failure, and intensify those unhealthy behaviors related to weight control. And so a lot of this is what our goal is, where is that mental health support coming in? So as we're getting into, if they are being prescribed GLP-1s, maybe seeing that therapist, maybe still seeing a dietitian, a lot of making sure who is it prescribed by? Are we getting consistent follow-ups? What are some strategies for maintaining emotional balance? So again, a lot of the work I'll do with clients is, what are our coping strategies? What are our grounding exercises? When we're kind of cycling between moods, how are we managing those? And then again, not seeking professional guidance for long-term success. So if we're struggling to having additional food aversions, if we're struggling with certain foods on these drugs, or if we're, what does that mean? And are we still gaining all our nutritional needs for kind of continued success and stability while on these medications?
So I wanted to go a little bit back to some of the research just in support of kind of the things we've been talking about today. And again, I don't want to get too into the weeds with this because this could get very boring, but I just want to kind of show you what research we do have, and then, show the gaps that we have that we need to study further to better understand and provide informed consent for our patients. So this study was called The Risk of Depression, Anxiety, and Suicidal Behavior in Patients with Obesity on Glucagon-like Peptide 1 receptor agonist therapy. So this was published in Nature, October of 2024, so very recent. And so as you can see, there is an increased risk of any psychiatric disease, major depression, anxiety, and suicidal ideation in the GLP-1 versus the non-GLP-1 groups of these patients. And so that is an important note to pay attention to. And then particularly in the same study, there is what appears to be a dose-dependent impact on that. So they looked at the different types of GLP-1s, and basically the list that they're ordered in here is like increasing potency, so increasing dosage of these medications as we go down. And as you can see, the risk of the psychiatric disorders is increasing with dose. And so this is an important thing to consider, if you are someone who's concerned about mental health side effects or having mental health side effects, is maybe that dosing needs to be adjusted. Maybe you're not going to get like maximum weight loss or maximum effect of the medication from a metabolic standpoint, but maybe we're reducing some of these other side effects. And there's ways of advocating for yourself, and as a clinician, appropriately monitoring your patient to make sure that the side effects they're experiencing are not worse than the benefits that what they're experiencing. And so I think that's just a really important note. And again, as Sehrish said, why it's important where you're getting this prescribed and the source of it and what monitoring is happening alongside it. This chart here is very overwhelming to look at, but basically this is a this is the psychiatric adverse events associated with GLP-1 receptor agonists, a real-world pharmacovigilance study based on the FDA adverse event reporting system database. So these are basically people reporting their own adverse events that they've experienced while taking these medications. And these ones in orange here are the most common. And as you can see, the top ones: nervousness, stress, eating disorder, top three, and then fear of injection, sleep disorder, binge eating, fear of eating, self-induced vomiting. So again, these are all eating disorder type behaviors. And so important thing to keep in mind is if you're someone who is at baseline at increased risk of some of these side effects, like maybe you have anxiety already, maybe you are already struggling with depression, maybe you've already struggled with an eating disorder, you may be at an increased risk of some of these adverse events. And these are side effects that should be monitored and addressed in your follow-ups with whoever's prescribing this medication. And I see someone had a question about going back to the last slide. So let me go back and make sure I can explain this. Was that on this slide here? Yeah, okay. So this is looking at the different types of GLP-1s. And basically this is what's called a hazard ratio. It basically is like comparing the risk for this group of people compared to a group of people not on one of these medications, and what is their increased risk over that period of time, which was 5 years for these medications and 3 years for Wegovy, of developing one of these conditions. So when that number is above 1, that means that risk is greater for the person using the medication than it was for the person not using the medication. And the further above 1 it is, the greater the increase of that risk. That makes sense? Does anyone have other questions on that slide? Okay, great. All right. And then this other study here that I wanted to mention. So these medications are currently being used under study for reducing the risk of the metabolic side effects of antipsychotics. So antipsychotic medications are primarily used in various mental health conditions that involve psychosis, schizophrenia being one of the most common ones, but they're also used as an kind of an adjunct or to augment the antidepressant therapy for people with more severe depression or with bipolar disorder. And so people who are taking antipsychotic medications, we often see will develop some metabolic side effects. So could be weight gain, could be increased insulin resistance, could be high cholesterol, could be high blood pressure. And this study was actually showing an improvement in those outcomes for patients using a GLP-1 alongside their antipsychotic medication versus those who were not using the GLP-1 and just taking the antipsychotic alone. So point being that there are some potential benefits in mental health conditions people who are already experiencing some of the negative side effects of other psychiatric medications could actually have some benefit from using these medications. All right. So coming towards the end here, and we'll have plenty of time for questions, but really the main points that I just wanted to really make is, and I think we've said this several times, is it does matter who prescribes this medication to you and the source of that medication. That really does matter, because this medication is so much more than just a weight loss medicine. In reality, it's not a weight loss medicine. It is a medication that is affecting metabolic health on multiple levels. And if you are experiencing some metabolic health conditions, this medicine is very, very, very helpful potentially. But there are also real serious harms. And, we didn't get into the GI side effects today, but that is something to consider. But the mental health impact is another important consideration. And it really does matter who prescribes it to you, if they're monitoring that appropriately, if they're taking into account your personal history or your family history of mental health conditions. This is not something that I would get in a strip mall. So, I just think that it's important. This is a psychoactive medication. It's important that you're getting it from a person who is properly educated and monitoring it properly. And, as I said, understanding your personal risk of some of these mental health side effects based on your personal history, your family history, and ensuring you have the right support in place if you are someone at increased risk before considering taking one of these medications, and that you have the ability to reach out to your medical professional or your mental health professional if you're experiencing some of these side effects, so it can be adjusted appropriately. I think the other important thing is, and again, this goes back to who's prescribing this for you, is setting realistic expectations. I think a lot of patients do expect rapid weight loss, and that's something that I think is one of the big contributors to some of the psychological distress, like Sehrish mentioned. But there are also some patients who do not experience rapid weight loss, and I think that psychological distress is very serious for those patients as well. They may see improvement in their metabolic health markers, but their weight may not change as dramatically as they expected, and that can have a lot of impact psychologically and socially, and all of that as well. So I think it's important to understand realistic expectations, to understand what the potential side effects could be, and then making sure that you are following that appropriately, so that if you're having a side effect that is greater or more severe than any benefit you're experiencing, you can adjust the therapy. And then, as Sehrish mentioned, and as I mentioned, that one of the things that happens with these medications, especially with the cost and access issues that we see now, is a lot of people are having to stop and start medications. And that is, in my opinion, the highest risk time for some of these more disordered eating behaviors, because you have a rapid removal of a medication that was controlling your metabolic health condition. You're going to get rapid increase in cravings. That binge restrict cycle is going to be really, really severe. And so making sure that you're alongside the medication, working on your mental relationship with your body and with food, and then integrating some sustainable lifestyle changes, so that if you do have to stop the medication, whether it's for a side effect or for an insurance issue or whatever it is, that you have less of a risk of experiencing that very drastic change. And as Sehrish said, weight cycling, that loss gain, that is more harmful metabolically to your health than staying the same and not losing any weight. And I think that's something that is not well understood or discussed very often amongst patients, is like, the crash dieting cycle, the yo-yo dieting cycle, it has its own separate harms, separate from anything to do with the starting weight. So that's just an important thing to consider. And then Sehrish, did you have anything else you wanted to add on that before we get into questions?
No, just kind of, I guess, going to hop off the weight cycling too a little bit. I think what we're also seeing, it's very similar to kind of like the refeeding syndrome. I've also been seeing quite a bit of that happening with clients as they're, again, going on and off the medication, as if, especially that malnutrition that kind of happens sometimes with clients. It can imitate a lot of the refeeding things that we see. And again, just kind of going back to what Rebecca was saying, that can be very scary and very harmful for clients. So,
yeah. Right. Well, I'm seeing already some great questions. So I'm going to start with the questions that we have here in the chat from Emily. So how do you think GLP-1s could change the treatment of binge eating disorder? Do you think it's appropriate to use with this population outside of the presence of medical need? So this is such a tricky topic. And I fully expect that there will be an attempt to get an FDA approval for at least one of these medications for binge eating disorder treatment. And I don't think it's necessarily inappropriate all the time, but it's also not appropriate all the time. I think the best use of these medications, in my opinion, is when we're seeing those metabolic side effects. That is where the risk comes from, right? Is long-term risk for diabetes, heart disease, strokes, all of these things, that's coming from those metabolic changes. So if you're seeing metabolic changes, these medications can be really helpful. I think the harm would be in using it to suppress the symptom of binge eating disorder by just like making it harder to binge, or suppressing appetite, or making it uncomfortable to binge. You're putting a Band-Aid on the situation if you do that. And I think that, we see this sometimes with Vyvanse, which is currently the FDA approved treatment that we have for binge eating disorder. There are a lot of patients who have maybe underlying ADHD or that spectrum of symptoms that's contributing to their binging, where Vyvanse is super helpful. But if you're just using it to suppress your appetite all day, you're going to get into that binge restrict cycle. And then when you come off of it, it's going to be more severe. So I think if it is going to be used in the treatment of binge eating disorder, I think it should be done judiciously. I think it should be done in cases where there is also metabolic stuff going on that is a potential risk to that patient, because that just changes that risk benefit ratio versus just to suppress appetite. I think you're potentially doing more harm than good. So that's an important thing to consider. And then the next question, the food noise. So people wanting to turn to these meds for non-medical reasons because of food noise. So this is another similar thing. I mean, food noise, where is the food noise coming from? Is the food noise because you've been restricting and so you're hungry and your body is trying to get you to eat? Is the food noise because you're not efficiently using the glucose and the energy that you take in because you have a metabolic condition and so you're feeling cravings for carbs, or you're hungry despite having eaten enough because you're not efficiently using that fuel? That's very different than I've been restricting all day and I just want to suppress the need to eat. And I think that's where it comes in with binge eating disorder. There can be situations where some of that food noise is, the body, there's a metabolic issue and you're getting these cravings that are driven by that metabolic issue rather than by a psychological issue. But it's important to tease that out. And this is not I guess my concern with this becoming FDA approved for that indication would be go into an office, slap on the medicine. They never see a therapist. They never see a dietitian. We never work on that relationship with body or food. And that is going to end up in that binge restrict cycle, especially when the patient eventually does have to stop the medicine for one reason or another. You're going to get a huge resurgence of that food noise.
And I think just to go off of that, I think what we've seen is how many hours are you thinking about food, whether it's that restriction or whether that's engaging in that behavior. And so when we see a reduction of that, whether we want to call it food noise or whatever that might be, I look at it very behaviorally. And it's like, okay, well, if we're not doing that, what else are we doing? And so with binge eating, a lot of times it's like, well, I'm constantly focusing on what my next meal is, what I'm eating next, or how am I attaining that. And so when that kind of slows down a little bit, now I can look at other parts of wellness for me. And now I feel like I can actually function and think about work or think about school or think about other things. And I'm actively more present in other aspects of my life. And so that to me can seem like a psychological positive. And so that's when we also see the changes of depression and anxiety also get reduced, because sometimes a lot of these, where's my next meal coming from? Or I feel kind of hopeless or helpless around food. When you see that reduction happening, that can be seen as, again, a positive in treatment and moving forward. But again, being able to measure that from a professional standpoint is very important, and having those sessions or having that weekly check-in or monthly check-in with your physician is pretty much where we want to definitely emphasize that.
Yeah. And I think, I've definitely seen that with patients who have insulin resistance, who didn't even realize how much they were thinking about food. Like they weren't engaging in any disordered eating behaviors. They did not have an eating disorder. And I see a comment about distinguishing between those two things, which I think would be important for you to do for us next, Sehrish, the difference between eating disorder and disordered eating. But some people don't realize the impact that that's having. And it's because they're, again, not efficiently using that fuel because of their metabolic condition. And they don't even realize what was there until it is turned off. And then they're like, I'm able to do the things that I've been trying so hard to do because now this extra factor has been removed. So I think that's a really important factor to consider as well. So yeah, Sehrish, do you want to sort of distinguish between the two of those things while we are before we get into the questions?
Sure. And sometimes I want to just say that so eating disorders, again, we have this idea that there's a consistent behaviors and then the goal with that is that I want to reduce the weight, and regardless of what physiological concerns or any other concern that might be, and that can lead to, even though the lethality of eating disorders, we are okay with that as long as I get the goal of which is loss of weight. Where with disordered eating, I feel like it can be different than eating disorders in the sense of I can have some things like orthorexia. I might be starting by just and I guess I should define orthorexia, where I'm trying to eat cleaner, or I'm trying to eat in a certain way that's just better for me, or I've been, and then that can lead to kind of an eating disorder. But really with disordered eating behaviors, I would say that, like I said before, with clients coming in sometimes, they might not have an eating disorder, but the disordered eating behavior could be like, hey, I just don't want to eat certain types of food because I think they're not good for me. Or that can be, I'm only eating, I'm doing certain diets where I'm eating some foods and I'm not eating others. I'm restricting parts of foods, but it's not with a consistent goal. I think let me think about another way of saying this.
I mean, I think the way I always distinguish it is like there's clear criteria for diagnosis for various
Mhm.
eating disorders, right? And disordered eating is sort of, maybe they have some symptoms but not all. But I think with any psychiatric diagnosis, a clear requirement for it to be a psychiatric diagnosis is that it's disruptive to social functioning or medical stability or health. And so, if you are occasionally binge eating, doing a fad diet and then having a cheat day, but like that's pretty disordered. But if you're still able to function socially, if you don't have like major health impact from that, that's very different than someone who is like very consistently restricting entire food groups, restricting to the point of nutrient deficiency, to the point of malnutrition, unable to engage in sort of like normal social functions, work function, school function, whatever the case may be. So I do think there's so much, it can feel like a lot of gray area because one can turn into the other, but there is sort of that more distinct criteria that you have to consider too.
Yeah. And so again, like feeling guilty or anxious about food choices, I feel like we all have those, but is that actually preventing us from going out and like engaging in certain activities? Or, I might feel a certain way of body image today, but that's not going to keep me from attaining events. I might skip meals, but is that regularly happening to the point where my BMI is underweight? And things like that. So that's kind of I think, yeah, but there's a lot of gray area there. I agree. So again, it's the consistency of those behaviors leading one way or another, I would say.
All right, some more questions. How do you feel about a client who takes a week off here and there for vacation to temporarily remove the side effect? So, I think the important thing to understand when considering that is like, what is the side effect and how severe is it? Because if it's severe enough, maybe we need to be reducing the dose or changing the treatment in general. We don't want people to be in a situation where they're struggling to function the majority of the time in service of like one particular blood test result or something like that. But, if there's a temporary situation where you decide to come off of the medication because, it's not a hugely bothersome side effect, but you're going to a wedding or you're going to like a big celebration or, something like that, and you want to be able to eat the food, like I don't necessarily have an issue with that. But I think the important thing is understanding the motivation behind it and understanding like, are we tolerating things we shouldn't be tolerating most of the time? And you're giving yourself that break, because that is sort of could be potentially a disordered behavior, right? To just tolerate severe medical side effects because, oh, it's keeping my weight down, versus this is like a low level annoying side effect that I want to not have to deal with when I'm on vacation. I think it just matters where that's coming from. And it also matters, what is the reason they're using the medication? How much of an impact is that going to have potentially on their control of the underlying medical condition that they're taking it for? A week is probably not going to make a huge difference, but there is an issue with these medications. Often you start at a very low dose and you gradually titrate up every 4 weeks or so. And so if you stop the medication for too long, you may have to start back at the beginning and titrate back up again to avoid the severe side effects when you restart the medication. And so it does matter, how long are you stopping it for, and how much of an impact that period of time of titration might impact your overall medical condition. So that's not a black and white answer. Next question, are you seeing insurance coverage for these medications in clients without diabetes? Most of my clients are having to get compounded form because insurance won't cover. So this is a huge issue. Insurances will change their mind all the time. We are never going to see a consistent coverage because these are expensive medications, and that's a whole other topic that I'm not going to get into. These are expensive medications. Insurance companies don't like to pay for things. They will find a loophole to not cover it. It very much depends on the plan, and it very much depends on the patient's other conditions. They have to meet baseline FDA approval criteria, of course, before they were going to be able to get any insurance coverage. And then also the insurance, often what I see is they actually carve out like, oh, we cover Ozempic and Mounjaro, which are the ones that are branded for diabetes. We don't cover Wegovy and Zepbound, which are covered for weight loss. Weight loss is carved out completely of the insurance plan. So you can get them covered if you have diabetes, but if not, it's not going to be covered. I see that a lot. Nowadays, both Novo Nordisk and Eli Lilly, so Novo Nordisk makes Wegovy and Ozempic, and Eli Lilly makes Zepbound and Mounjaro. They both have their own direct pay programs now to purchase these medications directly from the pharmacy at a more affordable price. Directly from the pharmaceutical company at a more affordable price than you would pay cash to go to a retail pharmacy if your insurance doesn't cover it. It's still not cheap. It's on the order of around $500 a month. So it's certainly not cheap, but it's not $1,300 a month, which is the baseline retail price. But I think, for me, when it's a discussion about compounding, like I cannot provide you adequate informed consent about a compounded product because it is not regulated in the same way that the pharmacy grade product that is available in retail pharmacies, it's not regulated in that way. And so I can't tell you, what's in it. I have a good friend who's a compounding pharmacist who, when all of this started, I asked him about this. I was like, where are you all even getting this stuff? Because this is a brand name medication. It's not like Novo Nordisk and Eli Lilly are just handing it out to random compounding pharmacies to make a competing product, right? So, and basically what he told me is like, there's no legitimate source that I can find for these medications. I know there are plenty of compounding pharmacies doing it, and some have better reputations than others, but I personally just don't feel comfortable with what this is even. And nowadays, and Guy just mentioned this, which was very helpful. The manufacturers have filed lawsuits. There's all kinds of things happening. Like the compounding is going to stop in its current form. They're going to find other loopholes, and we're going to keep kicking the can down the road. They'll mix it with something else or whatever to allow themselves to keep compounding it. But I just personally couldn't recommend that because I can't really give you an appropriate informed consent about that product. So, when I do have patients who struggle with insurance coverage and would otherwise benefit from the medication, we have a discussion about the direct pay programs. And I do have a lot of patients using those programs when it's appropriate. And while it is quite expensive, I think for the patients that I have that are taking it, they feel that the benefit is worth it, but it's certainly a huge access issue. The one thing that's been good about this whole compounding thing is it's kind of forced the manufacturers to come up with another solution and drive down the prices. And I think that will continue as well. Into the, like I said, these medicines are not going away. So this will be a continued discussion.
And again, going back to where you're getting them from and how much information they have around that. So I've definitely seen it where wellness clinics have started. I've heard clients say that they've gotten it from people who aren't licensed, or maybe even people who aren't as just not licensed and it's not regulated. And so is it, again, are you going to a wellness clinic or are you going to a licensed professional? So that's definitely going to depend on the empirical information that they're using.
Yeah. Well, and the thing for me too is like, I have a patient who was offered this at an IV bar, which I'm not going to go on my soapbox about IV bars, but anyway, went to an IV bar, was offered this as like an add-on, like, oh, you want to add this? The patient met zero criteria to qualify for the use of that medication. And so, if they don't even know what the criteria are and they're offering it to someone inappropriately, how aware are they of the other side effects of the monitoring that's required, of the safety of the product they're offering? Like it's a big concern. I think it's very important to consider the source and the education of the person that's providing it to you in your safety. All right. Last one I'm seeing here is how do you feel about these medications around PCOS treatment? So some of my patients with PCOS have been the ones that have benefited the most from these medications. PCOS at baseline, people with PCOS have insulin resistance. That's one of the features that contributes to the hormone dysfunction that they're experiencing. And I've definitely seen a lot of benefit for those patients. And, particularly when they're in that sort of like borderline diabetes phase. Like I've been working on all the lifestyle things I can do, but my blood sugar is continuing to creep up and up and up. I'm like getting towards the borderline of diabetes. This is a case where you're treating the underlying condition. And a lot of patients with PCOS do experience that like food noise that's coming from not being able to efficiently use their fuel, not because they're necessarily, deliberately restricting or anything like that. Now, I will also say, as I'm sure many of you here know, PCOS is a huge risk factor for developing an eating disorder. And that's because the behaviors that are often recommended to people with PCOS are, lose weight, go on a diet, cut carbs, all of these things. So it's a lot of people with PCOS do struggle with disordered eating or have or are at risk of developing an eating disorder. So it's an important thing to monitor. But I do see a lot of my patients with PCOS doing really well. And I wouldn't be surprised if there's also a plan to seek FDA approval for treatment of PCOS, because we don't have a lot of options for people with PCOS right now, other than just, treating the various symptoms associated with it. Right. Any other questions? I know we're at the hour here. Right, well, thanks everyone who showed up, and we appreciate y'all being here. I am going to send out the recording to everyone who registered. So if you need to rewatch a section, look at one of my overkill, messy slides about all these research studies. And all the citations are there as well. If you want to dig deeper into the study and look at that, you're welcome to do so. But yeah, we're happy to help. And then, if you are a patient or have you're a clinician, you have a client who could benefit from a more nuanced discussion about one of these medications with a physician who understands how to prescribe, I would be happy to help them. I am taking new patients at Vida, and I know Sehrish is available to help any patients who are struggling with the mental health impact as well.
Thanks for being here, guys.
Yeah.
Bye.
Bye.